We are going to bring up our next speaker, who's going to be Melvin Lawden, who's the co-founder and CEO of Develop Health. His talk is going to be on the prior authorization tipping point, how AI is transforming the landscape beneath our feet. So please help me in welcoming Mel.
All right. Well, we're a little bit ahead of schedule, so I'll do my best stand-up performance while we wait for people to filter in a little bit. No, I'll spare you that, but I will start off with a little bit of a preamble on who I am, who we are at Develop Health, and then excited to get into the topic. So my name is Mel Van Lunden. I am CEO and co-founder of Develop Health. We automate medication access using AI. And so we're based out of Menlo Park, south of San Francisco, team of primarily AI engineers, and so feel uniquely equipped to talk about a topic like this, about how we're using AI to fundamentally change how medication access happens. A little bit of background, me, so my background was pre-med and undergrad. As I was interviewing for med schools, I was learning how to code and fell in love with the idea of impacting healthcare at scale through software. Joined a fintech firm out of undergrad, built in-memory databases for hedge funds and banks as a software engineer, and then transitioned into design consulting. Worked 2 years at IDEO, a design firm, and then transitioned into the startup scene. Joined a company called Canvas Medical, built an EHR from scratch over the course of 5 years, led product there during my time there, and did a lot of the development work in the early days, and then led the product teams, design teams, and data analytics teams. Founded Develop Health about 3.5 years ago, along with my co-founder, Ben Easton, AI Masters, Coffee Meets Bagel, brought him to the US, and then he co-founded a platform called Rupa Health that aggregated lab testing in the functional medicine space. We started Develop Health with the general thesis that payer-provider connectivity leads to inefficiencies in care. We were searching for the right concept. We ultimately landed on medication prior auth as a burning pain point as we talked to hundreds of different providers. You know, the existing solutions in market are great. They took us from a fax and paper-based process and made them electronic. But with the advent of LLMs, we're going through the next natural progression, right? Taking an electronic process and bringing it into the agentic age. So that's what my talk is centered around, is this tipping point, specifically around prior authorization and benefit verification. And AI has already transformed the way we work. I'm sure most people in this room have been in a driverless car at this point. You know, when given the option, I'd like to take a Waymo over the alternatives. 90% fewer serious injury crashes than human drivers. And so if we extrapolate this from an environment where there's a ton of different variables, you have city driving, highway driving, you have pedestrians, bikes, to bring down, to improve safety to that magnitude is very impressive. And it speaks to the aptitude of AI to be able to handle complexity and reconcile with that complexity. ChatGPT is the obvious one. Of course, everyone here has had some touch point with ChatGPT. There's over 900 million weekly active users today. 92% of Fortune 500 companies are using it. And kind of a fun fact here is that this has been adopted faster than the internet or smartphones. Open evidence is the third example that I'm sure a lot of folks in the room have heard about. You know, this is ChatGPT-like interface on top of peer-reviewed journals. And so I was in a doctor's appointment the other day, and instead of saying, let me Google that, I heard, let me check open evidence, speaking to the widespread distribution that open evidence has seen in a relatively short period of time, now supporting over 18 million consultations per month. So it's already here. We're starting to see it in various facets of our lives. And now I'd like to frame the conversation really around how we see this getting applied to access. And I think a nice way to frame this is to think about the players in the ecosystem and think about what they might look like in a superpowered version of themselves. All right, who are the agents that we are employing on the medication access problem. And I want to preface this by saying, we're not looking to eliminate humans from medication access. This is, healthcare is a unique industry in that demand is abundant. Patients need care. Oftentimes, patients are underserved in the care that they receive. And so this is about unlocking that demand by increasing supply dramatically. Taking the overworked providers, the overworked medical assistants, the overworked FRMs, and giving them a superpowered harness to do their job more effectively so they can reach more patient lives. And so we're going to go through these three roles in the access place, and then I added a fourth one here around the agentic builder, and this is a little bit of a view into how we build product. And I think this applies generally to any sort of software-driven organization or even manufacturers as they're thinking about bringing some programs in-house or thinking about developing capabilities in-house as well. So we're going to go through the medical assistant, the workhorse of access, oftentimes underappreciated for the work they do. They drive the process. They're navigating the EHR. They're finding clinical evidence. They're going through submitting PAs, reading faxes, calling payers, follow-ups, generating appeals, doing as much work as they can to ensure that the patient gets on therapy. And unfortunately, their bandwidth is somewhat constrained to do all of this as effective as the ideal outcome. Then we're going to move on to the agentic FRM. So thinking about a field reimbursement manager, what does a field reimbursement manager look like with these superpowers? What are the tasks that they can support? What is that? How does this change their impact? Are they, rather than focusing on the top 10 accounts of a specific brand, can they reach the long tail now? Can they support hundreds of accounts by unlocking these agentic superpowers? And then, I'm sure there's a few folks in the room that fit the last persona here, the agentic access strategist. What does it look like to be superpowered with agentic tooling to figure out how your drug is performing in market, figuring out the appropriate operational steps to improve access in the market? So we'll get into that one as well. So here, we'll start with the agentic medical assistant. So this is the agent that handles the access lifecycle end to end, to focus on exceptions instead of processing every case. So now instead of a model where the work is done by the medical assistant is monitoring agentic processes to ensure that the patient gets the best possible outcome. So I'll go through a few use cases here. First one is before the visit even starts. Patient's coming in for a visit, and the patient has a long clinical history. They have an insurance plan. Those two things are known going into the visit. Now, how do we predict likely therapies from that? We're pulling from that previous medical history. We're looking at FDA indication guidelines. We're looking at prescribing patterns, historic prescribing provider prescribing patterns for a patient with that same clinical fingerprint. And this is all in service to figure out what are the medications that are likely to be prescribed. And going through that list so running these BV checks before the patient even gets in for the visit, before the encounter starts. This way we can display to the prescriber what medications are covered, which ones require prior authorization, the estimated financial responsibility, manufacturer support programs that might be available for those medications, copay assistance, and various other facets around those brands that they're likely to prescribe given these objective factors. So this is a super-powered MA, right? So ideally they're doing this before every visit. In practice, that's seldom the case. Next one is assembling clinical evidence from the EHR and answering payer questions directly from the patient chart. So this is taking lab results, vital signs, 4 years of encounter notes, and taking all of this disparate information from the system of record, saying, okay, what questions are we answering? What is the payer asking about? Are they asking about specific lab values? Are they asking about continued therapy? And how do we build the case around those questions? And so right now, oftentimes a patient's opening a chart. They get a notification from Cover My Meds. They open up that page. They look through the form fields. They triangulate with the clinical chart and try to answer the questions best they can with the limited time they have available. A superpowered agentic medical assistant empowered by AI does the heavy lifting. Instead of all this searching through the chart, we autofill those questions and present them for review. So we're autofilling the clinical questions and then adding explanations. The AI is explaining why it's answered the question in that way. It's pulling quotes directly from the source material so that a medical assistant can quickly review that seems accurate and grading its own confidence. So it can tell the medical assistant to spend time on certain questions. Next, we're talking about payer IVRs and payer-side bots. So the interactive voice response menus that plans are very, very keen to put in place. So instead of a medical assistant waiting on hold, navigating through that IVR, checking for status on a single patient, they can employ their agentic superpowers to do that for them. I've got this patient, we haven't heard back on this prior authorization. Can you check for status? As you may have seen in the last talk, voice AI is growing in popularity, and voice AI for status checks on PAs and in some cases doing BVs is a viable way to obtain that information. Now on the back end, what does it look like? Now we've gotten the prior authorization back. We've got a determination. Or it could be any sort of facts. It could be a determination. It could be a request for more information. And so the superpowered MA, or the MA today, has to read through the facts queue, figure out, okay, what's the appropriate next step here? The agentic medical assistant can automatically classify those faxes and suggest a next step. And so instead of reading through all the different fax formats and trying to parse the determination record or figure out what to answer for more information, the agentic process is doing the heavy lifting and then presenting it for review. And then the agentic medical assistant, never drops a ball. They can continue to follow up autonomously until determination. So if we haven't heard back from a payer, oftentimes that can fall through the cracks. But the agentic system knows what outbound request exists and can query with that payer until the determination is reached. Last thing around the agentic medical assistant is auto-generating appeals. So we get a determination letter back, it's denied. The denial typically has some explanation associated with it. So the agentic medical assistant or the agentic process that empowers the medical assistant can suggest the next step. Do we resubmit as is? We think the determination was made in error. Do we resubmit with additional evidence? Core evidence was omitted in the first submission, so we want to do a resubmission. Or do we escalate to an appeal? We think given the determination letter, there's likely grounds for an appeal here and historic appeals data. So let's auto-generate that appeal. Pulls in clinical evidence from the patient's chart, pulls in brand-specific guidelines from the manufacturer, pulls in determination data directly from the fax that came back saying that the medication was denied, and crafts the best possible denial letter for as a next step. So that's some detail around how we see superpowered medical assistants, right? What does the agentic medical assistant of the future look like? These are some of the results we've seen in practice with agentic medical assistants, taking a process that was previously 1.5 weeks and bringing it down to 20 hours from prescription to determination. Reducing PA handling time from 10 minutes to 3 minutes per PA. Reducing PA-related inbound patient volume. This is more related to providing status updates throughout the journey of the access experience and having the agentic process inform the patient of where they are in service so they don't have to ping their provider and say, hey, where's my medication? And then another kind of another interesting stat around BVs specifically is reducing the number of PAs per patient. Right? If you know what medications are covered, which ones are likely to be approved given the plan constraints, you can dramatically reduce the number of prior authorizations that you're processing. Next, let's move on to the agentic FRM. So the first one I mentioned previously, but it's really about the step change of how many accounts they can support, right? FRMs go out into the field, they consult with the providers prescribing their medications, and advise on best practices around prior authorizations, empower prescribers and their support staff to most effectively address access issues as they come up. And so the agentic FRM can now supercharge their abilities. Some agentic processes can go directly into workflow, like the brand-specific appeal guidelines that we talked about previously. This agentic FRM can also prioritize more effectively which providers need human attention and why they need human attention. And we'll get into this in the next slide, but this idea of progressive querying, being able to do plain text queries across data, right? We use this internally quite a bit. We ask questions about our data warehouse, and it surfaces answers to us. Similarly, an agentic FRM can employ that same sort of tactic. They can start to detect prescribing pattern shifts before they show up in claims data to get ahead of any sort of provider behavior change that they can get ahead of. They can monitor payer policies and surface gaps in the EHR with just-in-time clinical decision support. So when the patient is in for the visit and the provider is documenting the encounter, ideally the FRM is really on the provider's shoulder as they're interfacing with that patient and the documentation. So the agentic FRM is in workflow, is suggesting, hey, you missed this key piece of documentation, so this drug is likely to be denied based on that. They can prevent denials by flagging documentation gaps. So that's kind of what I just spoke to. Monitoring payer policies and surfacing gaps in the EHR is like, hey, this formulary is shifted. Let's notify the provider of that in EHR, in workflow. Generate practice-specific training materials. So this is a really interesting one. As you build the data set around how the access process works, and you have this ability to do natural language querying of that data, you can also generate reports for that practice. So rather than having it templated, here's best practices around a prior authorization, thinking about the exact pain points that provider group faces and generating a leave behind that is based on their actual errors or missed data opportunities. Last one here is the agentic access strategist. So this is somewhat in line with the FRM in some respects, but this is about rather than going through a quarterly report cycle or using steamed claims data, replacing the access strategist with a continuous real-time market intelligence. Ideally, not another dashboard that you need to log into and check out, but one that you can natural text query. How is my drug doing in this geography? What are my approval rates? How is this payer interfacing with this brand? So first line of defense is this natural query. The next modality of interfacing with the data is through alerts, right? Either through Teams or through email or through Slack, whatever internal modalities you're using today to keep it in workflow for the access strategist. So configuring alerts or working with best practice alerts to figure out when a formulary has shifted without you knowing, or when approval rates drop significantly for a portion of the prescribing population. Maybe a new clinical criteria was added. These types of alerts can be really effective for the agentic access strategist. And so they're identifying coverage barriers as they emerge, not 6 weeks later in the claims data. the last layer of inquiry for the agentic access strategist is generating reports, right? Oftentimes, managing stakeholders can be a task within itself. And so being able to generate those reports using free text interfaces and then passing them up the chain can be helpful as well. And then ultimately, we get to a place where you can launch playbooks with real-time payer intelligence. Here's a brand I'm bringing to market. Here are some of the therapeutic areas it's focused on. Here are the types of prescribers that are likely to prescribe this medication. What is the appropriate medication access framework we should use for this type of drug? All right, now we're going to go into the agentic builder. And then so the same AI that's powering access also transforms how we're building and scaling businesses behind access. This is a bit of a personal story because this is, our team is relatively small, but we have the output of 1 to 10x its size. We're shipping features in hours, not months. Previously a feature that took 1 engineer a month now takes days to design and implement. We can do AI code reviews at scale. So we previously noticed that we were spending a lot of time on code reviews and oftentimes pulling out stylistic differences in code and against the design criteria. And so we started using, this is kind of the wedge for us with AI. This is maybe a year and a half ago. We started using AI code reviews to do the first pass on a review and flag anything that an engineer should dive deeper into. And then we also employ this in different parts of the organization. Our engineering team, or most folks in the organization now have a microphone on their desk. So instead of typing into the computer, most people are dictating into the computer now. Tools like WhisperFlow have made that really effective, so that you can improve the bandwidth of communication with the device that's actually producing the output of the work. This can be really helpful if you're interfacing with ChatGPT, Claude, and there's subvariants within. With Claude, you've got co-work, which is really effective if you're working on a project, and you want to just talk with how that you want to progress that project by just talking to your computer. Claude Code has been absolutely transformative, along with Codex, which is ChatGPT's equivalent. Just being able to say, hey, This is based on a recent call. These are some of the pain points we've heard from a manufacturer. How do you think we should address this? Let's go through a plan mode first. It drafts a plan. You iterate on the plan, and then it's time to execute. And you say go, and it turns into execution mode. It does all the code, and then it tests itself. It's actually running the code on your computer in your remote environments to figure out if it actually implemented the plan that you set out to implement. And then you can query it to check it in various ways. And so this is, I think this is the largest step change I've seen in my working career, which is, not the longest, but it's really incredible what you can do with tools like Claude Code and Codex. And there's subvariants, right? Co-work with Claude and even more simply like ChatGPT Chat or Claude Chat. On the go-to-market side, I think what's important to touch on is oftentimes we're trying to figure out what providers to target and how to target them and reach them at scale efficiently. We contemplated buying a data set to augment this capacity and figure out, okay, which EHRs are these provider groups on, what therapeutic categories are they focused on. And then we realized, for a fraction of the cost and with a higher level of fidelity that's more custom fit to our needs, we were able to build this through Claude Code and through Codex to build an agentic process that takes list of MPIs, enriches it with the organization, enriches that with the EHR, and then automatically sequences that for our go-to-market teams, for our account executives, SDRs, to do a combination of calling and emails, drop-ins, and then analyzing that on the back end and creating tasks based on that activity. So our account executives are always focused on the highest attention, highest leverage moments for their assigned provider base. We also see this on the back end. Once we sign providers up and they start working with us, we've got a small team, so we have to operate efficiently for customer support. And so what does that look like? We're using tools like Pylon's a great example of this, where it can aggregate across multiple channels as email, Slack, phone calls, and pull that all into a single work stream in an AI-based interface so that we can use the APIs of our CRM or our customer support platform and triage our support issues effectively. Figure out which ones are high attention, figure out which ones are pieces of feedback, and then incorporate those feedback into a product roadmap. And ultimately, where we want to get to is, the more we can continue to abstract and supercharge our team to build at scale, to sell at scale, to operationalize at scale, to support at scale, the more we're just handling exceptions for those work streams and architecting the systems that service those functions. And so ultimately, we get to a place where the system itself is self-building operational patterns, playbooks from patterns across customer workflows. So we've gone through the agentic personas. Now, what does this mean for an access strategy? And this is a little bit self-promotional, so I apologize for that in advance. But this is really about how we engage with manufacturers or hub programs or specialty pharmacies. So we have the platform approach where we distribute to MPIs that you prioritize for us. So you give us a list of MPIs. We take that through that system I described earlier. Maybe many of those providers may be connected with us already, depending on the brand. And then we embed our BV and PA directly in the EHR. So provider engages with us. They do a 40-minute demo, or say it's actually more of a 20-minute demo. After that demo, conversion rates are very high into an EHR integration. And then we just work seamlessly in the background. Anytime a provider sees a patient, our agentic BV appears as clinical decision support. Anytime they prescribe a medication, regardless of the destination pharmacy, we're automating that medication access or that prior authorization on the back end, helping with appeals, doing the denial risk analysis, doing the next step analysis based on denials. And then we provide in return real-time data into how the brand is performing in market through that agentic interface, through dashboards. And this is customizable per brand, so we can bake in copay integrations, PA workflows, those FRM alerts we alluded to earlier. We're adding, this is growing quickly since we started this recently, but we're adding around 5 new clinics per week now, and we've seen 40% month-over-month provider growth on the platform. Now, the other way we interface with manufacturers or ancillary partners is through our extension offering. So this is form-fit into your existing medication access infrastructure. So we take the same underlying core product, BV and PA, and deliver this through existing access infrastructure. So this could be in the form of DTP programs, hub services, specialty pharmacies, any sort of venue where you're trying to improve access in an existing industry or in an existing form factor. We're an API-first product, and given the rate at which we can adapt to new workflows and new customizations using these AI coding tools, we can fit into many different form factors and turn on or off different features based on the context. So this is typically used where we're one step removed from the provider. So this is, the script's been prescribed to a hub service, or script's been prescribed to a DTP program, or has landed at a pharmacy or even a retail, specialty or retail pharmacy. And then we need to engage the provider. So we have a product called the HCP Front Door, which takes that claim denial or takes that initiation step and then gets in touch with the provider to autofill their prior authorization. So they open up our portal, they drag in their patient chart, and then we autofill the prior auth, and then they hit submit. And then on the back of that, we'll prompt them to integrate with the platform for subsequent requests. So this is a great way to improve on the state of the art today, which is largely cover my meds with these pharmacy-initiated prior authorization workflow. Rather than asking providers to fill in the form entirely, they use AI to autofill their forms. We're serving over 500,000 patients per month. We see an average NPS of 9.5 across our customers. So we've been able to deliver some good results so far. And this is all in service of a future where care decisions are made effortlessly, administrative work is eliminated, and patients are back at the center of care. Thank you.
Awesome. Are there any questions from the audience?
Thank you for the presentation. The only question I have is, what barriers are you seeing in the marketplace in terms of like a provider onboarding or like stickiness at providers' offices?
Yeah, great question. Actually, I'm just thinking now, I shouldn't say great question because that minimizes other questions. So it was an average question at best. What are we seeing in terms of provider adoption friction? I mean, the way we approach the problem is with that as a core principle, right? What are the design criteria we need to minimize that concern? And the most important things for us are we need to make onboarding, a single phone call. Less than 20 minutes, we have to be able to get a practice up and running. The other one, and that typically involves integrating with the HR marketplaces so that you can easily get installed within those contexts. And also making sure that the workflow is fully subtractive, right? We don't want to be adding or retraining staff to do different things. We want to take exactly what they're doing and just remove steps. And so that effectively requires no retraining because now you're doing the same process, but just less of it. And then the third thing is we want to be, we can't do any provider behavior change. No prescriber behavior change. So we can't tell them to prescribe to a non-dispensing pharmacy. We can't tell them to change their pharmacy destination behavior. We want them to continue to prescribe, either aligned with the patient's best interest or with their existing pathways in mind, to ensure that we can offer a pharmacy agnostic solution. And so what that looks like in practice is we're listening to the EHR for scripts going out the door. And so we get one time configured, takes less than 20 minutes, then a prescription goes out and we're automatically activated, regardless of the destination pharmacy. And so I think that's been unique to our approach versus some other players in the market, is this idea of fully subtractive, very simple integration, and no prescriber behavior change required. And that's really unlocked stickiness in a big way for us because that single configuration event ensures that we're involved for all subsequent downstream scripts.
Great. Any other questions? Oh, sorry.
No, we operate through a BAA with the provider. So no patient opt-in required. We can operate in contexts where under a patient authorization, depending on some of the confounding factors. But so we have operated in patient authorization use cases, and we operate directly with a BAA from the provider or the pharmacy. Go ahead. Do you do pharmacy and medical, or just pharmacy? Oh, that question's the bane of my existence. So we currently are exclusively pharmacy benefit. And that's really in service of being very focused on on building a great product with one vertical in mind as a starting point. We've been able to develop our direct connections with PBMs as a result. We've gotten to volume very quickly. That's imparted cost burden on PBM partners and incentivized them to build direct integrations with us. Now we're planning to run that same playbook on the medical benefit side. So we will have support for medical benefit by the end of the year. but not currently.
If anyone has questions, I'm sorry. You mentioned that in the very beginning, it can look at what products are on formulary, what products has a PA. So does it influence the product selection at all? Like if your product, I'm on the manufacturer side.
Yep.
So if your product, let's say, has a PA and there's another drug that doesn't, is it going to influence that decision-making for the provider?
It could, in all honesty. So we are being as objective as possible. The way we're framing ourselves in market is as a neutral arbiter between PBMs, pharma, and providers. And so with that in mind, what our system does by design is take the patient's clinical fingerprint, prescriber's previous prescribing patterns, and then builds a best guess of what drugs might be prescribed in the visit. And using that information, we are presenting what's covered, what prior authorizations are required, the estimated financial responsibility to the patient. And so based on that, it may influence their prescribing patterns. But we don't want to materially change that because that could be construed as steerage, right? Like we want this to be an objective function for the provider. And we want to ensure that it's aligned with what the provider would likely select, given no outside influence. So we are surfacing those plan constraints objectively. And so alongside the clinical factors that patient presents with, the provider's weighing those plan constraints alongside those clinical factors to make a determination. But the upshot is for manufacturers, if there are support programs, bridge programs, PEP programs, copay programs, discount cards, those can be incorporated in the proactive benefit verification. So it's not just, this requires a prior authorization is $1,000, but with these manufacturer support programs in place, the patient actual out-of-pocket could be much lower.
Okay. Any final questions? Oh, perfect. Getting my steps in.
Thank you for this information. I think it's really fascinating. And I know that it's pharma focused, which is why most or all of us are here. But do you see future potential for these agents to enhance things like hospital-based registries and things like that? I work in a highly regulated oncology space. So what I do is kind of specific, but I'm thinking there could be a way to operationalize and make our registries more efficient in the future.
Yeah. The scope of the conversation was fairly narrow on access with respect to pharmacy benefit, and more centered around benefit verification, prior authorization, which are our sweet spots today. But you can imagine, as we think about applying this into other avenues, we were really building three assets. One is around clinical policy distillation, understanding how payers want to adjudicate certain transactions. Two is around transmission, thinking about how we handle electronic communications, AI phone calls, human fallback where needed, fax, finding the appropriate routing. And then three is around clinical data distillation. So pulling data from charts and distilling that down to answer questions that a payer may have. And so we're starting in pharmacy benefit prior authorization, expanding into medical benefit, medication prior authorization and access. And then you can imagine this applying to a number of other transmission form factors as well. Other types of prior authorizations, labs, imaging, procedures, services, into claims coding and adjudication, into risk adjustment, value-based care reporting. So, we stay very focused as a starting point, but these agents and the general assets we're building can be universally applicable to a number of use cases. I don't know too much about the patient registry use case specifically, but I'd love to chat after and learn more to see how that might be addressed with agents.
I have a question about distribution networks. So when a manufacturer has a specific, say, limited distribution network, how are those partners or pharmacies made aware of the involvement of your application before receiving say, an approved prescription, or maybe one that's still pending a PA determination? Walk me through that component.
Yeah, so we're initiated in cases where we're integrated with the EHR, we're not being initiated from a pharmacy-initiated touch point. In cases where we're proactively initiated based on the script being written, we oftentimes will clear the denial, clear the authorization before the pharmacy runs the claim. And so the pharmacy will run the claim, and instead of receiving a 75 code denial, they'll just be able to reimburse right there and then. And so we're not disintermediating the script at all. You know, we are trying to unblock the prior authorization as far up in funnel as possible. And so in cases where limited distribution specialty pharmacy network, you know, there are cases where we may not initiate proactively. And in those cases, they'll land at the pharmacy, they'll run the code 75. If we're integrated with them, they'd initiate our HCP front door, or they'll do the Cover My Meds in some cases. And in Cover My Meds, if that lands back into the EHR, which oftentimes it does through the fax ingestion pipeline, our system listens for those as well, and then auto-initiates the prior authorization based on that fax coming in. Does that answer your question?
Great. Any final other questions? Okay, perfect. Thank you so much.
Thank you all for your time.
Awesome. And with that, it does conclude the tracked programming for PAP today.